Hey everyone, this is Ensign Flood. So today let's talk about leukemia. So just kind of as a puzzler to get your minds warmed up, I put up a blood smear of one of the leukemias we'll be discussing. So I want to see if you guys can guess what it is before I get there. All right, so looking back to pre-clerkship days, you kind of had this scary looking differential tree of how a pluripotent stem cell will basically differentiate either into a myeloid progenitor or a lymphoid progenitor. So basically these are the basis for our different types of leukemia. So as you probably remember, lymphoid goes to lymphocytes, so B and T cells and natural killer cells. Myeloid essentially goes to everything else, whether it be RBCs, platelets, mast cells, monocytes, basophils, etc. All right, so when we think about working up all of these different leukemias, the approach should actually be pretty straightforward. If we have a suspicion of leukemia, so things like fatigue, maybe bone pain, weight loss, etc., then we want to do a CBC with a diff, right? So bone peripheral smear. So to be even more specific and diagnostic, a bone marrow biopsy is gold standard, but if we want to get really technical, some things that we might be asked about would be fluorescence in situ hybridization, or FISH for CML based on the translocation, or flow cytometry can be extraordinarily specific and accurate, but it's really expensive and kind of a burden to do, and those are popular for lymphoid leukemias. So kind of going into the different types of leukemias, I like to think about it like a little Punnett square. We have acute and we have chronic. We have myeloblastic and we have lymphocytic. So AML, ALL, CML, CLL. All right, so let's get started here. So basically AML, you're going to see somebody who's about in their 60s or so, middle to older age, and they've probably had a history of either radiation exposure or maybe they've had CML in the past that is now rapidly starting to gain these cells called blasts and entering into a blast crisis. So the thing about blasts is that blasts are basically these really poorly defined cells that you're going to see in either acute myeloblastic or lymphocytic leukemia. And when they get to over 20%, we consider it an acute case. And their non-specific level of differentiation kind of comes at the expense of all of the other cells that could differentiate. So these people will get infections, bleeding, fever, anemia, pain because of the lack of all of the cell types downstream that they could have become instead. So the treatment type for AML that's really popular if it's an M3 variant is the all-trans retinoic acid, or ATRA. And this is basically given to M3 that is basically positive for our rods, which I'll show you here in a second. And if it's not positive for an our rod, then you'll want to go chemo. So ALL, I like to think about a cute little kid because ALL is the predominant cancer in pediatrics. So about 85% of these kids will get a T or B cell based ALL. 15% get T cell. So kind of the same story in terms of the infections, fevers, etc. But with the kids that have the mediastinal mass, they're a little bit older, typically teens, so T for teens, they're going to get a mediastinal mass as well. So the treatment for these kids is chemotherapy, and you also want to do basically a neuroprophylactic intrathecal ARA-AC. So then in terms of CML, I think of M for middle-aged and minimal symptoms. Basically, they're going to have a CBC with differential one day, and it's going to look crazy because they're going to have all of these different types of myeloid progenitors. So your promyelocytes, your metamyelocytes, your myelocytes, and they're going to have a lot of basophils. So I want you to hold on to that because it's useful later on. The treatment here is imatinib, which is really important. They like to test it a lot because it's the first targeted therapy against a translocation. So remember I talked about that FISH or fluorescent in situ hybridization. That's because imatinib basically targets the translocation 922 or the Philadelphia chromosome, and I'm going to try to help you remember that later. So ALL, I like to think about lymphocytic leukemia as being the extremes of age. We talked about ALL being the little kid. Chronic CLL is older people, and so typically, again, they have minimal symptoms. They might have viscosity. I like to think about kind of like all of the different IgGs that B cells create, but you guys can remember however you'd like. So the support here is typically minimal because since they're kind of older, they're likely to actually pass from something else first. But if they are younger, you probably want to get them stem cell treatment, or if they're symptomatic, do some chemo for that viscosity. The major risk here is that you can get this thing called a Richter transformation into a large B cell lymphoma, and this has a really poor prognosis. All right, so I just want to show some blood smears since sometimes these are tested on. So again, AML, Auerrod, M3, treat with ATRA, right? Sometimes you might see myeloperoxidase because that's what's inside of neutrophils. So myeloperoxidase positive, Auerrod positive. All right, over here with ALL, the big thing is like AML, you're going to see a whole bunch of blasts, right? We talked about greater than 20% is the magic number. And then I mentioned before that for lymphocytic leukemias, we really like to do a lot of flow. So that's going to be for CALL, and I'm sorry, it's hiding. This is TDT. In terms of CML, we want to look because it's going to be really this heterogeneous type of smear with the basophils. You can kind of see basophil here and here. And it's going to have that translocation of 922 on fluorescent in situ hybridization. And then CLL, again, it's most accurately diagnosed with flow cytometry, but then there's this weird finding that happens if you slip a blood smear, and basically these cells kind of burst and create these smudge cells, and apparently this is pathognomonic for CLL. So then you have a couple of good distractors. The major one I find to be distracting is the leukomoid reaction. So to me, it kind of looks a little bit like a CML. It's going to have a lot of neutrophil progenitors, but it's not going to have basophilia like CML. And the thing about leukomoid reaction is it's actually a benign stress response to like a cold or something. It's just you get really high neutrophilia, so greater than 50K. Myelodysplastic syndrome is basically in elderly people who have bone marrow that's really hyperplastic, but none of those progenitors seem to be differentiating and getting out to the periphery. So you can see here in the smear, it's sort of really sparse. So pancytopenia effectively. If it's a young enough patient, you want to do a stem cell transplant. If it's an older patient who progresses to AML, consider chemo. Otherwise, you just watch these patients. So finally, I just want to do a really quick translocation roundup because you might be pimped on this. You might get this on step 1. So here we go. So Burkitt leukemia, or lymphoma, sorry, Burkitt lymphoma. Mantle, I like to remember this by, if you think about a mantle above a fireplace, you have a candle on each side of it. Follicular lymphoma, 14-licular lymphoma. And then T15 through 17, sorry, this is kind of a stretch, but I think about like teens that are 15 to 17 saying FML, I say AML. And in terms of T922, so I think about Philly cheesesteaks. So Phillies are cheesy meat logs for 922. So again, translocation, right? It's a big chunk of chromosomal material going from one chromosome to another chromosome, and that's traded out, as you can kind of see the final effect here. So in summary, signs and symptoms of leukemia, work them up with a CBC and a diff. Then do the bone marrow biopsy. There's some fancy tools later on, but this is kind of gold standard. Acute leukemias are symptomatic because of all those blasts, greater than 20%. AML is going to have the Auerrods if it's M3, treat with ATRA, otherwise chemo. ALL is going to be in peds, so chemo with intrathecal ARA-AC. Chronic is going to be insidious, so your CLL is going to be in the really old people, so do the flow or the smudge cells and beware of Richter transformation. CML is going to be middle-aged, right? So they're going to have the really heterogeneous type of smear. Don't mess that up with leukomoid reaction, which does not have all the basophils. That's a benign stress response. And finally, myelodysplastic syndrome is really chock full hyperplastic bone marrow, but low production in the periphery. All right, guys, great job. Keep studying hard.